دكتور حاتم tremendous effort يعني وإن شاء الله نستفيد ونفيدونا كمان إن شاء الله. طيب non-invasive testing modalities يمكن زي ما قال دكتور حاتم, it's been one of the things that me myself actually I had a problem with it since the early of in the residency actually. It was always difficult to understand which modality should I use and when should I use it, and then how can I get benefit from it. We know that we know that coronary heart disease in cardiology بشكل عام, it has a big burden on the on health and in economy, and of course atherosclerosis, which is the coronary heart disease, remains the major cause of death and the premature disability worldwide. As many studies have shown that there will be a risk, even those who are free of any risk factor, they still have a risk of lifetime coronary heart disease. So what is the spectrum of heart disease usually? We know the common cause, of course. I'll try to start from the scratch actually, how it will start. We know that the coronary heart disease is basically because of this atherosclerosis with the plaque formation, and that will lead to either blockage or a different mechanism that will lead to the formation of or the starting the cascade of the ischemic heart disease. Now, the most common presentation for us would be the chest pain. It's actually represents around 50% of the initial symptoms. The other symptoms, which is like angina equivalence, dyspnea or early fatigability and exercise, it remains the other, or represent the other half, and usually it's shared with other non-cardiac conditions. The problem will be in when they call you for a chest pain. We know that when we are covering ER, from different specialty will receive a call that I have a patient who will have a chest pain, and it's always like a worrisome for everyone. Even the patient themselves, nowadays they have a low threshold to come to the ER department seeking for help regarding this chest pain, even though that couldn't be cardiac related, but they will come to you anyhow with a chest pain. And sometimes the specialty that they face or the first encounter with them, they might not have the full ability to assess them very well. So they will call you, and you might have around 10 to 20 calls regarding this chest pain. So the best way to deal with it is to have an algorithmic approach of how can I understand this chest pain in a way that it will help the patient and will be cost effective and help the health system itself. Now, I had the questions in the areas of my young residents that why when I have a call at 1 o'clock a.m. and patient come with a chest pain, I was thinking then why should I bother myself with doing all the things that trying to get lots of hard time to figure out, is this a pain that I should admit, or this is pain I should discharge? This is a patient who represents a high risk for me, or this is just something that's non-cardiac and I should refer to other one. So why should I just admit all of those people? I do for them, all of them, coronary angiography and solve the problem really. With the chest pain, you just, if you know, at the end of the line, more of the patient will end up in the cath lab on the table and doing coronary angiography than we should do for all of them while we are having a suspect coronary artery disease, and it will solve the problem for us. Now, of course, this is not the ideal. It might sound like logic, but it will not be the right answer, of course, because coronary angiography is like an invasive procedure. It's expensive. It carries its own risk. And of course, having the many complications, and we know that the complication can happen to the normal coronaries more than the diseased one. You can send a patient who's having a normal coronaries and end up with a dissection, and you will face a lot of complication that you were from the beginning should avoid it actually. So, as I said, until recently, angiography has been the major approach to assess the patients for the presence of coronary heart disease. However, cardiac cath is less than ideal screening tool since it is expensive, invasive, and exposes the patient to a risk of complications. But the critical questions remain, however, regarding which modality will be the optimum and how can I choose it. Now, if you try to approach the patients from the beginning, those who came to you in the emergency department and they don't have any known coronary artery disease before, and they present to you with the chest pain. So you start with doing what? Of course, history and examination. You will ask for an ECG and cardiac enzymes, as we all do. Now, this one will end up in what, actually? In three possibilities. First one is that the patient is clearly having an ACS in a form of unstable angina, anesthemia, whatever. And then you know how to deal with it and with the ACS protocol and etc. The other possibility is that this pain is actually non-cardiac at all, which is you can discharge him or send him to wherever the source of the pain is. Now, the one in the middle is the patients who are having suspected coronary artery disease. So now you need to do more effort of trying to understand where you will put those people and how you will approach them. Now, we know that the pain can be related to many things. Even cardiac itself could be ischemic or non-ischemic at all, or pulmonary, GI, whatever it is. So how to approach it? First of all, you need to understand when they call you regarding a chest pain or angina, all of them are now freely talking about angina. However, there is a specific definition and classification for this angina, actually. Whenever we go to the ER and we ask these people about the chest pain and they told you that it's typical, and you figure out later on that this is a non-cardiac one. So how can I tell that? The typical angina, of course, it has three categories. It has to be retrosternal chest pain lasting for a few minutes, that is provoked by exertion, emotional stress, relieved by rest or NGT. The atypical one that has 2 out of 3 features. And the third one, which is a non-anginal, has only 1 or none of the 3 criteria. We have another terminology, which is the chronic stable angina. That is angina that has been stable in frequency and severity for 2 months or more, in which it is only provoked by physical or emotional stress. Now, based on this, now you have a patient who's having already chest pain. You try to understand his pain is like anginal, atypical, or non-anginal pain. Then, according to the Diamond and Forrester in the 1970s, they came up with a way that depends on the age and the gender and the pain. Then they can classify those people who are at low risk, who are at high risk, and who are at the intermediate risk for coronary artery disease. And you can notice here that women who are less than 50 with an atypical chest pain and men who are less than 40, they have a low pretest probability of having a coronary artery disease. And the women less than 40 and men less than 40 with a non-anginal pain, they have a low test probability. The others, they are in the intermediate part. But then how this will help you? The next thing that you need to know, they did an update in 2014, the guidelines. They add that those people who are having a low risk of pretest probability, if they add one of these risk factors, then they will put themselves in the intermediate category. Who should I test among these patients? I have a patient who already, I did the initial assessment for myself, and I understand his chest pain, whether it's typical, atypical, or non-anginal pain. And now I have his age, and I have his gender, and I have the risk factors, and I can put it in one of these categories. Then what? What should you do next? The ideal, ideally you should test them. The intermediate, the low, or the high. إذا ممكن أحد يدير أي فكرة.
The intermediate ones.
And why is that?
Because whenever the pretest probability was high, better to do invasive testing. And if the patient is low risk, it is no need to do any further investigation because it is non-cardiac and atypical with low pretest probability.
Okay. Here الفكرة إنه the way that you need to test those people who are in the middle. Why? Because whatever the test results will come, it will either you will send them to the high risk people or to the low risk, and they will rule it out. If you test those who are in a lower pretest probability, you need for them whatever test you choose, and it came to be positive, there is a high chance that this is a false positive. You just brought your patient from the low pretest probability to the intermediate one. So you didn't actually do anything. And in the other way around, those who are high risk, if you test them and the test came to be negative, then you will say that they are not having a coronary disease, and you send them back home. But in fact, they do have it, and you did a test that gives you a false negative one. That's why you need to put your effort on the intermediate, where you will understand how you will send your patient to which direction. Not only that, the test is not only for ruling in or ruling out your coronary disease, like it gives you as well a prognostic part, a prognostic information that will guide your further management. If you even proven that this patient is having coronary disease, it's not that it is not enough, and you need to further decide which treatment you will go, which modalities you will choose. Is this one is only for medical treatment, or he will deserve to go for coronary angiography? Because we know that coronary angiography by itself, or BCI, is not a solution for coronary artery disease, and it's like a symptomatic relief, no prognostic part, unless of course for the left main LAD, proximal LAD. Whereas generally, your BCI is not the solution every time. So that's why you need to categorize them very carefully. Now, starting with the initial, you had your patient, you assess him, you did the initial assessment, the examination, the history, and the ECG, and the cardiac enzymes. You ruled out that this is not an ACS. The pain is like atypical or anginal, and with the risk factor that the patient is have, you put him like he's a low pretest probability. In the same time, you need to assess two things. Is he able to exercise and having an interpretable ECG? Those people, you will do the first thing is exercise ECG. It's like class 2A. Exercise echo will be class 2B. Exercise MBI, pharmacological stress testing, both of them will carry class 3. What is obvious here, in the low pretest probability, there's no class 1 indication for doing for them an exercise test, whatever it is. Even if you believe that he is having a low pretest probability, and you believe that you still want to do further testing for them, you can do that. It's reasonable. And the first test should be done is the exercise ECG. But it's not as a class 1, because we said from the beginning, low pretest probability, they should not be ideally to be tested. Like if you believe that the patient, case by case, he need to be investigated, then you can go for exercise ECG testing as a class 2A. Exercise echo as well will be carries like 2B, but exercise myocardial infarction, myocardial perfusion scan is you will not, of course, expose the patient to irradiation, those who are having a very low pretest probability, and those who can exercise, but as per guideline, you will not choose the pharmacological stress imaging. Now, how about those patients who are having an intermediate to high pretest probability, who are able to exercise again and having interpretable ECG? The class 1 is exercise ECG now. This one carries a class 1 indication. You have already a patient who he's in the right category to be tested, and in the same time, you have assessed two things: exercise, ability to exercise, and the interpretable ECG. Number 2, you can go for exercise imaging, whether this is an echo or myocardial perfusion scan. This carries a class 2A. Cardiac CT or angio carries 2B. Again, pharmacological stress testing, you will carry a class 3 whenever the patient is able to exercise. You will never go for any pharmacological stress testing. Those patients category who are, I'm talking about the people with no coronary artery disease before. because this algorithm is actually applied for the same people with a stable ischemic heart disease who need follow-up, that which we'll talk about them later on. But patient who's having intermediate pretest probability, they are able to exercise, but their initial ECG is not interpretable. You have to tell me why the ECG, or what do we mean by the uninterpretable ECG? Those people exercise echo or cardiac MRI class 1 indication, pharmacological stress CMR class 2A, and the cardiac CT or angio is a class 2B. Now, low pretest probability, they cannot exercise, obese or having any joint problem or lower back, and they cannot. So the best thing is to do go for cardiac CT as a class 2A because they are low pretest probability. And again, you will not, if you are willing to do for them a test, then the CT angio will be the appropriate one. Number 2 will be the pharmacological stress testing imaging. It carries a class 2B. Now, those who are intermediate pretest probability and able to exercise, pharmacological stress testing will be the one carries class 1 here to be carried out. Now, what do we mean by interpretable ECG? It means that normal ECG or right bundle branch block is still interpretable. If you have a 1 millimeter or less than 1 millimeter ST depression, is still interpretable. Those who are having LVH but without a repolarization, they are the people who are interpretable ECG. Now, what do we mean by able to exercise? Just doing their ordinary daily activity is considered as able to exercise. I want someone to volunteer. This is a 40 years old female. She's diabetic, dyslipidemic, complaining of left-sided chest pain, which has been induced by exertion, not radiating and not relieving by any factors. She had it actually twice in the last 1 month, and she came to you with the ER, and you were the first one who was facing these patients. Among the others, they already have been called you about. What you will do now?
Hello, السلام عليكم دكتور مجدي.
أيوة.
Okay, I'm Dr. Yasin. Let me take this case.
Hi, أيوة Dr. Yasin. أيوة. So the ideal thing to do what next?
Okay, because the patient came to ER, so first I will take more history, detailed history.
Okay.
Then I will do examination. Then I will do investigation, mainly ECG and the cardiac enzyme.
Right. Now, clinical examination is actually unremarkable. Initially, ECG is not significant. The serial cardiac enzymes are within normal. What next?
Okay. So next,
category you would put this patient?
She is diabetic, so should be in intermediate.
Okay.
She is diabetic and she is dyslipidemic, so should be intermediate.
Okay. So what next?
So next, since she's able to exercise, she will go for exercise ECG.
You should actually ask for that. Like, okay, you assume that she can exercise. Like so you will send her home or you will admit her?
No indication for admission till now.
So we'll send her and we'll advise for?
Yeah, because serial cardiac enzymes are within normal and the ECG also is normal.
Right. Okay.
So she can go home and appoint her for exercise ECG.
Okay. Now, now you're the one covering the exercise ECG, and the patient came to the next day, and she's willing to do it. How would you counsel her before starting the test?
For starting test, I will tell her that we shall ask you just to follow our command, that we shall put you in a device which you will start as running. When you got a chest pain, tell us, or if you became fatigued, also tell us, because we count the time. So if we finish the time, we shall stop you spontaneously. But otherwise, before we stop you, if you feel pain or became fatigued, tell us, and we shall monitor your blood pressure.
Okay, sure. And I'll be running from the first minute.
Sorry?
I'll be running. You said that you will put me in a treadmill and I will be running, right?
Yeah, the running will be started by first by walking, then slowly we shall increase the rate of the running till she became more running.
Right. So the
start by walking.
The speed will increase by time and the incline will increase as well, right?
Yes.
And you already give her, you explain the test, you explain what are the things that you, if she felt it, you will stop the test and they start. Anything else regarding if she's on medication, anything you will advise before the test? Or should be advised before she come to the test next day or whatever the appointment is?
Yes, there is something like that, but I didn't remember the medications which she should avoid, but I think beta blocker should not take beta blocker.
Okay, ideally they should stop their beta blockers before that. Okay.
Beta blocker.
Yes, you start with your exercise ECG. This is your ECG, and her initial blood pressure is 130/95. Her heart rate is 67. You would like us. This is her resting ECG. So you'd like her to start.
Okay, so this is showing it is sinus rhythm with normal axis. Rate approximately 1, 2, 3, 4, approximately 75 or 70 like that.
Can I start? Can I proceed?
Yeah, you can proceed.
Okay. So she already started the test. This is her blood pressure is now 145/95. Her heart rate is reaching 150. The time is now 5 minutes so far almost. And anything?
Yeah, the ECG showing the ST segment depressions in inferolateral leads. Inferior lead 2, 3, AVF, and in the lateral leads V4, V5, and V6. Yes, there is a ST segment depression.
Sure. So do you want me to stop the test?
Yeah, I think it is enough because there's clear feature of ischemia.
Now, the ideal thing is that you should ask the patient if they're having any chest pain with these changes, and if they don't have a chest pain, they can continue. Then you should continue on that. Why is this?
Yeah, because if she has a chest pain, that means she's going to develop possibly maybe good infection. But if no chest pain, this may be tachycardia induced ST segment depression.
But I mean, if you stopped it at this time or you stopped it at 10 minutes, will it make a difference for you? If you already have an ECG changes, you already saw it, and the patient denies any chest pain, and she can continue.
This will be early termination, so it may not be conclusive because the patient, she didn't develop symptoms, and I terminated early.
Yes, so you should actually continue that because the purpose of the test is not only showing the ECG changes, but as well as assessing the functional capacity of the patient herself. Yes. If they don't have any indication for termination of the test, then it should be carried out until at least you see the maximum meds that the patient can reach. Okay, but so she continued, and this is now she reached almost 10 minutes. Heart rate is 150, blood pressure reached 160/95, and the ST depression is still there. And do you want to stop? She's now telling you that I'm fatigued and I want to stop the test.
Yeah, if she became fatigue or chest pain, she will stop.
Okay. So this is the recovery ECG. After she recovered and we
yes, almost it came back to the base.
Okay. So now, which protocol you have followed in this one?
A PROS protocol.
Okay. Any other protocols you know?
Yes, other protocols are there, but we are not using only using PROS protocol.
Okay. There's what we call actually modified PROS protocol. It's the same like the PROS protocol, but we use it for those who cannot, elderly people, but it's okay. How would you consider that this test is optimum for you? You already saw the
test is positive.
But how it will be optimum? I mean, would we say that this test is maximum or sub-maximum? Based on what you can say that?
No, it is sub-maximum because she didn't complete the full time.
Why? Yeah, it depends on the time, and it depends on you have a certain thing that you need to reach before you said that.
Target heart rate. She achieves the target.
Reaching the target heart rate.
Which is what? What do you mean by target heart rate?
85% of the
of the predicted for the age.
Okay. So do you know the engine?
كنت 220 ناقص 43 كنت تقريبا 177
5% and she reached already 150. So this is optimum, right?
Okay.
When you should terminate the test?
Terminate the test if the patient develops symptoms or if she reach the target heart rate. And if there is no ECG changes or no symptoms even, we shall terminate the test.
Usually there is a specific indications, or what we call absolute indication for termination. Number one, if the patient develops sustained. Okay. Number two, if he developed a ST elevation, obviously they should stop the test. If their drop in their systolic blood pressure is more than 10, okay, with evidence of ischemia. If they do have a severe anginal pain, of course you will stop. If there is a patient desire himself, he said that he's having dizziness or whatever, he wants to stop, then you will stop the test. There is an absolute indication for you to terminate the test. Right? Now, what are the indications for exercise from the beginning? What are the indications that you know for patient to go for an exercise stress test?
Atypical chest pain without ischemic change in the ECG.
Anything else?
Intermediate risk for coronary heart disease or low risk?
Okay.
Assess functional capacity.
Okay. Anything else?
And to assess symptoms in valvular lesion.
Okay. We can
diagnosis of arrhythmia.
Okay.
After 6 weeks of acute coronary syndrome.
So what you do, the right thing is to categorize it. And of course, you need to do exercise stress testing for those who have a suspected coronary heart disease, as we said, those who are intermediate. You need to rule in and rule out. And of course, in the same time, you need to get the prognosis. Number two, you need those who are having an arrhythmia, right? You need to look for any exercise-induced tachyarrhythmias or any what we call coronary incompetence. And in the structural heart disease, like asymptomatic severe aortic stenosis or hypertrophic cardiomyopathy, but you need to understand actually what are the indications for exercise stress tests. It's not only for coronary heart disease. Yes, we are discussing here in coronary heart disease. Like in general, you have to know all indications for exercise stress testing. One of the common tests used every day, so you should know which indication for the test. What are the absolute contraindication for exercise?
Obvious ischemic change in the ECG.
Yes.
Obvious ischemic change in the ECG.
Obvious ischemic. What do you mean by obvious ischemic changes in the ECG?
Yani high probability. Patient with high probability of ischemic heart disease.
What else? Yeah. Again, there is a specific contraindication, or I will call it absolute contraindication, to go for this exercise stress testing. الحاجة الواضحة ولا
يعني إذا كان if there is يعني acute myocardial infarction or the patient present with NICU new bundle, left bundle branch block, or high risk of unstable angina.
Okay, high risk of unstable angina, acute MI. Yes.
On the other hand, if the patient have a severe aortic stenosis,
Yes.
uncontrolled arrhythmia,
Perfect.
or the patient is hemodynamically unstable from start or in severe symptom of heart failure.
Okay, yes, perfect. أو باقي واحدة. Aortic dissection, okay? So again, acute MI within the last 2 days, high risk unstable angina. Of course, you can do the one with a low risk unstable angina. Still, those who are having an ischemic heart disease who came with an ACS, and they are at low risk, they can risk stratify them by the exercise stress testing. But high risk of unstable angina, you will not. Acute MI within the last 2 days, of course not. Uncontrolled or any unstable arrhythmias, of course not. Any symptomatic severe AS, you will not put them definitely on the treadmill. If they do have uncontrolled symptoms of heart failure, if they are in heart failure, definitely will not exercise them. Aortic dissection, of course, will be the absolute. Again, you have to know what are the exact absolute contraindication for exercise stress testing. What is the limitation for the exercise stress testing? Limitations, and I said we discussed the contraindication, but what do I mean by limitation? Any ideas?
If the patient have any joint problem or problem in movement.
Okay, so you have a physical, something that related to the patient himself physically, he cannot do it. This is one of the limitations, right? Obviously, and if they're going patients who are able to exercise. If you ask you this question, then you will say that patient physically cannot do it. This will be one of the limitations. The other limitations will be what?
Is it interpretable or not?
So what are the uninterpretable? We said, I said already the one interpretable. What do we mean by the uninterpretable?
Bundle branch block.
Excellent, number one. Number two.
Baseline steady depression from the start.
But more than what?
More than 2 millimeter.
1 millimeter.
1 millimeter, I mentioned before. If you have
already
yes, if it is more than 1, then it will not be a type. Number 2, number 3.
ST elevation in the ECG.
This is also a contraindication to it. Okay. What do you have else? Any common that you can find?
Pacemaker.
Yes. If you're already in a pacemaker, you will not do, of course, exercise stress testing. What is the things like, مثلا, pacemaker, other than pacemaker? WBW, okay? So again, WBW, ventricular pacing, complete left bundle, ST segment depression more than 1 millimeter. And if in the right bundle branch block, if the ST depression is more than the V3 and beyond V3 actually, from V1 to V3, if you have depression in left side, fine, but if it's beyond that, you will not do it. Otherwise, right bundle branch block, still you can exercise them, left bundle not, ventricular pacing no, WBW no. So these are the limitations. The limitations you have to divide in something that's related to the physical activity of the patient himself and the ECG part. Right? This patient, she reached how many minutes? بمعنى آخر, which stage she reached this patient? She exercised for almost 10 minutes. So that equals to what?
Stage 4. This is 10 minutes.
Okay. Each stage is how much? How many minutes?
3 minutes.
3 minutes. Stage 1 is equal to how many minutes? 4. Okay.
4 minutes.
فالمسج هنا انه you need to exercise them even if you had an ECG changes, which is of course not the one that will stop them. If they develop an ST segment elevation, you will not say that the patient can continue. Of course, if they develop a significant arrhythmia, of course not. But however, if they have an ECG changes, you still need to keep the patient to continue exercising, because the duration of the exercise matters for you, because as much as they can do, their meds will increase and it will affect your prognosis, of course, right? Type. Now, you are sitting in the clinic, he already, she did the exercise testing and she brought it to you. You're the one seeing her primary physician. They said that the patient underwent a post protocol. She exercised for 10 minutes almost. Maximum blood pressure, she reached 160/95. Her heart rate reached 150. She didn't have any chest pain, but there was obviously 2 millimeter horizontal ST depression. What would you do next? You're a primary physician and she's sitting in front of you and waiting for your response. What next should be done?
Hello. Yeah, we shall take her for echocardiography, then coronary angiography.
Why?
Because echocardiography, we shall check if there is regional wall motion abnormality. We suspect which territory of artery will be affected. And second thing, we can assess the valve. Because if the patient having any valvular lesions, and if there is an indication for valvular replacement, so here the coronary angiography will be as a diagnostic, and the patient may go for CABG.
بمعنى آخر, you finish the test. Okay, they put for you the test and the result, of course, and the patient done it. إيه الخطوة المفروض تتعمل بعد the patient who finish?
To explain to the patient what's the result of that.
Yeah, I already actually explained to the patient, بس أنا أقصد إنه في part missing في exercise testing you should do. Anything to be calculated.
The recovery phase should be also recorded after the completion of the exercise test.
Do you have any score that you should calculate it?
Team score or grace score for?
لا, this is from.
No, exercise test score, but ما مذكر اسمه. fixed Bruce score.
Duke score.
Duke score, right?
Duke score, yes. Yes.
Yeah, you should. This is an equation. It should be known by heart. Because the patient, the aim of the test, you already have done it. Then you need to know how significant is the test for you. Yani. It's not about only when you find an ST segment depression, meaning that you will put the patient on the table and you will do for them a CAD. No, definitely no. You have to. Every test that we will discuss, so uncanny exercise, echo, MBI, whatever, there is always a features in the test that is going with low risk, intermediate, high risk features. Those who's having a high risk features on the test, they should go directly for PCR or whatever, intervention. Those who are having a low risk and intermediate risk, then you will understand there is further management should be done. فقبل ما نمشي اللي بعدها, can someone calculate it هنا? This is the report from someone to calculate exactly in your office. You should calculate it, and then you will. أي واحد حافظ المعادلة وعارفها.
هو actually the maximum exercise time in minutes.
Okay.
Minus 5 multiplied by the ST segment deviation in millimeters. Minus 4 multiplied by the which is called anginal index.
Okay. والانجينال index كيف تتحسب؟
هو يعني 0 لو there is no angina. 1 يعني non limiting angina.
Okay.
و 3 هي exercise limiting angina. Or 2 is exercise limiting.
طيب عشان برضه انا بتلخبط فيها بالعاده انه it's graded from 0 1, 2.
Yes.
Again, you have to know it by heart, this one. The Duke score, the time minus 5 multiplied by the ST deviation. Here it is 2. Okay, we said that 10 minus 10, 0 minus 4 by 0, right?
Yes.
What do you do next?
According to the score.
Okay, then you had a score. What you will do with this score?
Yani if the score is more than or equal to 5, it is indicate low risk for a cardiovascular event.
Okay.
يعني
what do you mean by a low risk? Anything has to have a definition of that. Anything you have to be very specific to understand.
Low risk.
The low risk معناها أنه the patient in front of
يعني
you.
the prediction of the coming I think 4 years survival was تقريبا 99%, something like this.
Okay, the annual mortality rate is less than 1%. It's actually 0.25. But this is the low one. How about the high risk? The cut point.
أنا اتكلمت عن survival, but I didn't know the mortality.
Okay, that's fine. And now, زي ما قلت في there is a high risk findings. You have to find it on exercise. You have to know it in the exercise stress testing, all the tests that you will discuss later on. Number one, if they develop an exercise-induced VT or VF, this is one of the high-risk findings on exercise stress testing. If they have, of course, if they develop exercise-induced ST elevation, this is one of the high-risk features. If there is, if the ST depression was at a low workload, you just put the patient and they didn't finish only stage 1 and it showed that they have a ST depression. Or the ST depression actually in the recovery phase, after you finish the test, the patient has to stay in a recovery. You have to be monitored for at least 5 minutes to see the first of all the resolution of this ST depression. At the same time, because sometimes they develop arrhythmias like PVCs, and this is actually has been correlated with a poor prognostic factor actually. The ST depression, if it happens very early or it persists in the recovery phase, this is one of the high-risk findings, by the way. Okay. Number 4, a hypotensive blood pressure. من الbeginning I have put the blood pressure in each slide. One of the things that you need to concentrate on is not the only ECG. You have to concentrate on the blood pressure itself and the heart rate itself. Okay. The blood pressure, if it fails to increase more than 120, then this is a very high-risk findings on the exercise. But these features called the high-risk features on the exercise ECG. Okay. طيب exercise ECG بمعنى آخر prognostic markers. As I said again, duration مهم, workload, the angina and when it happens actually, any hemodynamic in terms of the blood pressure as we said, and the ECG findings. فهي 4 يعني it's not only the ECG findings that you are looking for. The Duke treadmill score. The next step المفروض تعمل مباشرة انت خلصت التست. Things that you need to interpret it انك تعرف ايه الاكشنز اللي حتسويها انك تعرف السكور how you will understand it يعني. So if you calculated and it became more than 5, then this is a low risk score, صح? What do you do next? And I have a depression, but the score was low. What do you do next in the category of the low risk patient? Yes,
Need no further investigation.
ولكن نحتاج
Coronary angio.
No. They need a medical treatment. بمعنى آخر, the exercise ECG specificity or sensitivity for detection of the coronary artery disease has a modest sensitivity. The patient, if he is fulfilling that he's having the risk factors of chest pain, you find that ST depression in the ECG, but the whole markers is not going with, there's no high risk features, and the patient is not لا هو intermediate ولا هو high risk. So you need to treat them as a stable coronary artery disease. فكرة إنه أنا everyone who's having coronary disease will be sent to coronary cath. This is يعني الكونسبت المفروض يتغير. هو يعني المفروض الواحد يعرف إنه which one that you will just write for them whatever beta blocker or statins and control the risk factors, send them home. This patient مثلا والله عندها chest pain, only it happens twice, wasn't that typical. Yes, she have risk factors. You put her already on the test, and then you find that okay, there was an ST deviation, ST depression in the inferior leads. طبعا بغض النظر عن الديتيلز المرة، لكن even the inferior leads they're false negative or false positive actually. لكن let's say إنه هي أنت اعتبرتها هي positive, and you calculate the risk, the score, the Duke score, and you find that it's more than 5, and there was no high risk features. Those people will deserve just a medical treatment. Now, الأسهل الثاني هو the high risk score, people who's having a score less than 11, having a risk of what? Their annual risk mortality is more than 5% per year. That's why you will send them, those people into the هترسلهم إلى الكاث. Okay. Now تيجي الناس اللي في النص اللي هم intermediate risk. You calculate for them and it's like between 4 and -10. Those people, as per guideline, need further investigation, usually imaging. Okay. معايا ولا؟
Yes.
Yes, you're following.
Yeah.
Right. And as I said, based on the Duke score, it provides both as a diagnosis and prognostic. إيه قصدنا بالprognostic means يعني what further medication. Okay, you proven that the patient having coronary disease, لكن مش معناها أي واحد عنده coronary disease need a cath, right? Now, those who's having a low risk score, you will treat them medically. Those who's having intermediate risk score will need a further assessment, usually imaging. And those who's having a high risk score, high risk features, yes, those will go with coronary angiography later on, whatever they need, BCI or chemistry or أيا كان. Okay. طيب now نجي واحد familiar with طيب mechanisms of the SPECT. احنا النيوكلير عندنا two things، حاجه اسمها السبكت وحاجه اسمها البت. اوكي. السبكت اللي هو single photon emission computed tomography. احنا ندي في العاده tracer injected to the patient which is taken by the cardiac myocyte. التريسر ده سواء كان we have many tracers that like technetium or rubidium or whatever. These tracers emits gamma radiation and it will be captured by the camera or the CT and converted to a digital slice. Now the image you get it, they will the image will be like in a short axis. You have a vertical long axis and you have a horizontal long axis. Okay, and these are the images you will get. It will be arranged in the first one will be the stress part. The one in the second row will be the normal one. The rest actually, and you will compare the rest with the stress. Okay.
Yes.
Right. طبعا هنا قلنا the donut shape. You have the segment here, similar to the echo. The lateral one, the one above it is the anterior, the septum, the inferior. How you analyze images like this? How you analyze it? Usually, number one, by the location. You use again the 17 segment model اللي هي مستخدمة في الإيكو. You measure the extent or the amount of the abnormal myocardium. بمعنى these segments بتشوف كم segment بالضبط اللي هي abnormal. 1 to 2 segment هل تعتبر small, medium, or large if it is more than 4 segments. You have to understand as well the severity and amount of the reduction of the tracer uptake and the types of the defect, whether it is reversible or fixed. This is the models. Each model, each segments, you need to know which artery is supplying. Now, what we do usually by using the 17 segment model, this one, you assign it to the perfusion grade. بمعنى, there is what we call here. Okay. The color, the yellow color itself, you will see it إذا شفنا المسكة الأولى اللي هي على اليسار مع اللي تحت. How much is bright بمعنى آخر بيسموها hot. How hot it is, it will be more yellowish صح. and how now you will grade it. إذا كانت أخف من كده it will be graded to from 0 to 4. according to the grade you will give يعني it's not only the defect itself. again زي موضوع ال ECG مش موضوع ال SC depression بقدر انك انت you need a further information to get it from this one. So they usually get how they try to grade it as much as possible. في حاجة اسمها اللي هي السكور. as I said they scored all the segments 17 segment اللي أنا هشوفها. they score it and they grade it as what we call there's a sum stress score severity of the stress perfusion. okay. وفي ال sum stress score ال SRS وبتروحوا الاثنين من بعض وبشوفوا how it reflect the induced reflect the stress induced ischemia. معنى آخر you can see هنا إنه there is a number. النمبرز المحطوطة هنا اللي هي 1 أو 3 أو 2 أو 3 الجهاز الموديل أو الكمبيوتر بيقيسها إنه how yellowish it is or how hot it is وبعد كده how it is the defect. if it is مثلا 4 لو لاحظتوا رقم 4 المكتوب ده there is nothing no activity at all right. that means it's infarction. okay. but this will give it as a 4. أما اللي هي very good ولا normal one will be given as a 0. بيجمع في الستريس بدي رقم كل ال 14 سيجمنت بيقيس كل 14 سيجمنت بيجي لكل سيجمنت بيشوف بديها كم بالضبط من 0 to 4. لقى والله الايبكس في الستريس لما we put him on the stress ال radiation كان او emission من this segment كان والله very good normal تماما so it is 0. لا والله كان في defect مثلا 2 or 3 وبعد كده انت بتجمعها كامله في الستريس بارت. again وبتدي نمبر معين تقول والله كان الايبكس كان 4 في stress and then you calculate the rest one بحيث انه the same بدي له كله grade في الرست. انا بديت ما اخذت المريض ما اديته لا medication for pharmacological ولا exercise and we put him in the scan and then you will calculate these numbers that you will then تطرح من بعض. فكل ما كان الرقم عالي معناه صح like this مثلا it's like 8 كل ما كان عالي that means there is a reversible ischemia. نحن انت لو في الايبكس هو في الستريس وصل الى 4 صح ما كان في النهايه ان ريميشن. لما دخلته في الرست وصل الى 0 فكل ما كانت 4 minus 0 الريزلت or the sum is 4 that is a very high number. فبالتالي that means there is a reversibility. والعكس صحيح اذا كان في defect مثلا بمعنى fixed defect meaning that والله في الرست وفي الستريس 4 minus 4 is 0 that means انه ما في it's a fixed defect or there is no reverse. معنى اخر there is no reversible ischemia لانه الهدف من التست or the myocardial perfusion scan واحد to know how much you do you have a reversible ischemia or not. There is a reversible ischemia يعني or not. Number 2 of course if there is a defect or fixed one وفي other informations like اللي هو coronary reserve flow لكن يمكن advanced شوية. طيب again any test الأشياء المفروض أو تسأل عنها في العادة إنه any test you have to know what are the high risk features. In the myocardial perfusion scan if they get a lung uptake this is one of the يعني لو صوروا المريض and then they found the tracer is being uptake by the heart and it went to the lung itself. This is high risk features. Number 2, if there is a transient ischemic dilatation due to extensive ischemia, this will be representing high risk features and معناها there is extensive ischemia in the subendocardium. Number 3, if there is a large defect, and you have very large defect area. Number 4, if there is an RV uptake, the right ventricle cell has been uptaking the tracer. And number 5, if there is a drop in the blood pressure, especially those who will do for them exercise MBI. طيب, this is the lung uptake. Usually في الجهاز بتبين لنا كده. You have already stress. الline اللي فوق ده stress واللي تحت rest.
Excuse me, sir.
أيوه.
Regarding the previous slide.
أيوه.
طيب يعني إذا جينا لقينا إنه lung uptake is one of the feature of high risk feature.
Yes.
طيب the RV uptake, why it will be also the high risk feature? يعني the lung indicates that there is no uptake by the heart muscle, so that is go to the lung. So why RV
mass
من اللنج.
Okay, the RV, how is the LV compared to the RV? يعني
how what?
Okay, the RV mass, the LV mass, if you compare it to the RV, it's 3 times the RV. Ideally, it should be taken all by the LV. لكن إذا كانت عندك already defect or a very extensive ischemia in the LV, then that means, and the RV has been taking this tracer, فأنت it represents for you that the LV as مع إنه هي very bulky muscles, it didn't take anything and it allowed the RV to take it. This is one of the features that he will explain that this is a high risk feature.
Okay, so. Okay.
And if you allow me here يا مجدي برضه there is one thing لأنه طبعا usually هو the tracer is taken equally by the LV and RV. But this nuclear scan is about relativity. So the shyness pixels are taken by the LV, and this will dim the rest of the pixels. They will be dim. So if we have LV ischemia, the LV will go weaker and the RV will appear relatively stronger than the LV. That's why its own shining will appear. It was actually dimmed away because the LV was strong. Once the LV goes weak because of ischemia, it shines through. Okay? So it's a sign of a global LV ischemia and weakness.
Yes, exactly.
Good?
Okay.
Thank you.
طيب this is الصورة الثانية اللي هي TID أو اللي هو transit skin dilatation اللي لاحظتها the first row, which is the rest compared to the stress compared to the rest. There is obviously dilatation, okay, in the cavity, and this is again goes with the extensive or high risk features. Again, like any other test, you have to understand what are the contraindications before you send the patient to the perfusion scan. Those who are hypotensive will not go for a test. Anyone who's having an ACS within the last 24 hours will not go for the test. Severe aortic stenosis, severe LV OT obstruction, severe LV or heart failure, and if they have any allergy to the material that you will use. Back to our case, this is the result. That female, actually, she had كنا حسبناها حتطلع لنا intermediate risk, and then you send her for further testing, and this is the images you got. Again, in your office, she went and they did the images, and she came back to you, and this is her. And they didn't report it yet. Actually, they didn't have a time to report the image. But you opened it in your clinic and you are seeing it, and then what else you would do? So the question will be, what is the best action that would be describing the next step for this patient? She has a cardiac or myocardial partial risk of less than 1%. There is a TID high risk features. PCI will be the proper choice, and she should be sent for to improve her symptoms and decrease the risk. And there is no role of medical treatment at all here. I would say, what do you think about the test, Aslan? Check it out.
There is a reversible ischemia and LV dilatation, I think, cavity, so signs of high risk.
Is there any defect? Can you appreciate any defect here? Huh?
There is a large impacted area.
The horizontal and no, it doesn't show any defect in the horizontal and vertical. There is no visible defect.
No reversible defect. طيب ايوه ايه دي بالضبط؟
It is fixed and female. We can talk about artifact.
Okay. Yes. This test actually is a normal test. طيب. Number one, ما في any reversible defect هنا. Okay. This part usually they call it a black cat or dropout عادي بيكون موجود لأنه because of the annulus. Okay, so it might look like a defect, but it's not actually. And if you see in the horizontal and in the long axis the same, everything is normal. So this test is basically normal, right? Or actually, this is how the normal test will look like. Okay. What would be the answer here?
It is not B, it is not C.
Huh?
It is not B and it is not C.
In the context, again, in the context of our patient, اللي هي جات في البداية عندها atypical chest pain and she already hospitalized her and you found the ECG findings, you calculate the score, she was in like an intermediate to the low, and then you said that I want to further investigate her, you're not happy that much, and then you did for her the MBI, and it came like this. So what is the best thing, or what you will say? قلنا هنا normal صح؟ B? Why B? طيب the right answer is A actually صح؟
B,
yes. Yeah.
We said this is a normal one. TID is not a feature here. BCI, why would you send the patient to the BCI?
No indication.
No role of medical treatment. لا. You might, there will be a role of medical treatment لو أنت تحتاج تعطيها whatever. If you prove to be whatever, you will give her medical treatment. For the best thing to message هنا, the patient has a cardiac risk or myocardial risk of less than 1%. Now, as also now again, like any other test, like an ECG or exercise ECG, the result of the test that you will get, you have to put the patient or you classify your patient أو تعرفوا إيش الفيتشرز في any test تعمل إيش بتخلي التست ده والله this is a low risk, this is an intermediate, and this is a high. The same applies for the exercise هنا. A low risk test means that you have a normal MBI, a normal global coronary reserve flow, معناها إنه أنا عندي risk of annual mortality is less than 1%. So you reassure the patient, send her home. Intermediate risk, that means اللي هي عندهم mortality or annual mortality risk of 1 to 3%. L features بيقولوا this is والله intermediate if they have a stress-induced moderate perfusion defect without LV dilatation and without a DID and no increased lung uptake, ولكن هي moderate perfusion defect. أنت حسبت already the score. You calculate how many segments is there, how many vessels is there, and then you said that this is والله moderate, and that means أو عندها intermediate decrease in their global CFR. That means the patient is having intermediate risk. Those category في exercise ECG, those category needed an imaging. In this, it's a medical treatment. You send the patient on a medical treatment. However, if it fails, those patients you will send them to a PCR or any contraindication, whatever that you want them to reveal. Now, high risk patients, what do you mean? They will ask you, what do you mean by the high risk patient? Those who carries more than 3% of annual mortality per year. فبالتالي what are those people? هم اللي عندهم stress-induced large defect, those who are having a stress-induced multiple perfusion defect of moderate size, stress-induced TID or lung uptake, if there's a drop in the ejection fraction more than 45%, or there is a severe reduction in the global coronary reserve flow. But these features has to be memorized well بحيث انك انت you need to interpret the result. يعني if they give you the report and already has been the final conclusion they said والله this patient has a low perfusion, it's a low defect or it's a small size, what you will do next? If it is والله this one carries an intermediate risk, what you will do next? And this one has a high risk features. Always you have to think about the next step. what do you, because you're the cardiologist who's dealing with those people, فبالتالي you need to know what is the next management. Okay. طيب هي كنت حناقش الاشياء ثانيه بس قلت انه لو خليها على 2 sessions ممكن بحيث انه ما تكون very heavy. ممكن نناقش مثلا next time السي تي ونجيب more cases عن ال MBI و the same يعني.
شكرا لك كثير يا دكتور مجدي، جزاك الله خير.
Excuse me, Toya, I have a question.
Thank you so much. And to be continued, yeah.
Inshallah, next.
Inshallah.
Inshallah.
Thank you. This was really amazing. Thanks a lot. Thank you all of you, and see you next week.
شكرا جزيلا. شكرا.
شكرا جزيلا.
شكرا جزيلا. Thank you so much.